coincidence that I'm speaking after Priyanka. There were so many things I was finding similarities with when you were speaking. We talk about a service, and then we talk about doing a pilot, and then we say, what next? How do we take it to scale? And it is not about just the design of the service or the technology that we're using. It is so many other dynamics that makes it sort of, successful or not at scale. So yes, I will also talk about service, which is mainly targeted towards the rural part of the economy and towards mothers, and in the spirit of inclusion to the family members. Okay. How do you, I don't see the, yeah, thank you. MAMA is a global program, Mobile Alliance for Maternal Action. It is now running in 3 countries, Bangladesh, South Africa, and India. But Bangladesh is the only country where we have taken it from pilot to national scale. A little bit about Dnet. Dnet is a 12-year-old social enterprise based out of Bangladesh. We incubate innovations. We spend enough time in building innovations, taking it to replicable models, and taking it to large-scale programs, either ourselves or through our sister organizations or through the partner network that we have. The program that I'm talking about today, the service, Aponjon. Aponjon means your close one, Apnajan, close one. And it is majorly targeted toward MDG 4 and 5. Things are bright, but also there are some stats where we know that, a lot of mothers, in the absence of very simple informations, mothers and their family members, there are neonatal mortalities and mother deaths at the time of delivery or during pregnancy. And today we have talked enough about mobile penetration. It is true that mothers, our rural mothers may not have a mobile set belonging to herself, but she has access to mobile. So the household has a mobile which she may have access in the evening when the husband comes home, or maybe her neighbor has a mobile that she has an access to. So I remember that even when I was small, we used to stay in the quarters where there used to be one phone or one television, and people used to sort of run around and things like that. So there is heavy access to mobile phone. So keeping that in mind, we designed this service called Aponjon. It is actually targeted towards behavioral changes of mothers and their family members and contribute to a reduction of maternal and neonatal mortality. So vision-wise, that's clear. We want to reach a lot of people, otherwise behavioral change is not going to happen. And that's why scale and sustainability has been in our radar from day one. A little bit about the service model. We provide health messages, 2 messages a week to the mother based on her week of pregnancy or till her baby is 1 year old, based on the baby's week of age. Messages are available both in IVR, that is voice, and SMS. It is available in both voice push and pull. So most of our mothers, it is a matter of, they may not dial and listen to the message. So her phone rings at a designated time of day, her preferred time slot, because maybe the phone is not available in the morning, maybe the phone is available to her late in the night, or maybe it is available to her in the noon time. Whenever it is, she can choose her preferred time, and at that time, her phone will ring and the character will talk to her on that, just like you were talking about the doctor character. A reliable character talks to her in form of a voice. It is also available to other segments of the spectrum in terms of SMS. We understand that inclusion is very important to empower the mother, to empower the woman. We need help of our family members. Thus, messages, the service is also available as we say, gatekeeper. So her mother-in-law or her husband or any member of the household can also register for the service, and they then get messages relevant to them. So it's personalized messages that they get, not the same one. I will come in a bit to the business model. It's a paid service. It's 2 taka per message. I should also say, before questions come rushing in, that no, it doesn't cover the cost of the service delivery today. That's why there's a business model to see how when the grant dries up from USAID or Johnson & Johnson, how are you going to sustain? And I'll talk a little bit about those bits in a bit. As we have done comprehensive formative research when we launched the pilot in 4 districts with only 1,200 people, and we took feedback on content, on service design, on pricing. Again and again, we heard our mothers saying that we really love these messages. These messages help us because it comes twice a week. A frontline health worker comes once in 30 days or 45 days in Bangladesh. But these messages come to me every week. So it's like a dialogue. Sorry, it's like a line, but I want to dialogue. I want to talk to somebody. And just a month back, we have launched our counseling service where our subscribers can call and talk to a doctor. It covers all content area, as Priyanka was saying, the danger signs of pregnancy, the preparation that she should make to get a safe delivery done, either through a trained midwife or the nearest health facility that she should visit, and how well in advance she should prepare for that, baby's vaccination times, the nutrition, hygiene, etc. The content, again, was developed from scratch by our team, reviewed by experts at government health levels, by WHO, Johns Hopkins. And we have a content revision, dynamic content strategy by which we are already in our third revision of content. Just a bit on content. The content is available in urban and rural version, so the same content is delivered differently to a urban mother than to a rural mother. Like rural mother, it goes in a drama format. But whereas we found that our urban mothers like a more straightforward approach. It is also personalized based on, as I was saying, mother, subscriber, mother, husband, or mother-in-law, etc. We are also currently working on getting the 2 dialects that are mainly used in Bangladesh. We are working on that, on content. I think I have covered that. Registration. Again, it's so very important to have a sort of cover a lot of channels of registration. Otherwise, how will you reach numbers? Thus, our registration can be done, self-registration is possible through SMS or through IVR. We have found that that's not easy for a rural mother to follow our IVR. Even when I call my bank and they start talking in IVR, I just look for the option where I can talk to a customer representative. So how do we expect them to do that? Thus, our outreach, they monopolize the value-added service landscape. So they're not connectivity providers. The connectivity providers, they're also service providers. Thus, when somebody else comes with a service, we get called as content providers, not service providers. And it was a big challenge to technologically integrate as well as strike revenue sharing deals and to have one shortcode, as Priyanka was saying, across mobile service operators. One of the other challenges was differential charging. This is the only service in Bangladesh which has differential charging. The service gets charged at different prices. So for 80% of our mothers, it's 2 taka. But for mothers who are, single mothers, mothers who have deliverers as husbands, and some other factors, they get it free. So they get charged 0 taka. So same shortcode, same mobile operator, but different charging. A little bit on business model, and I hope this is the last slide, and I hope I'm in time. So what happens? What happens when the grant goes down, or Johnson & Johnson decides to put their money in something else? And that is where we have been thinking of generating revenues from other sources. One of the things, just to give a few examples, we have come up with Sponsor a Mother gift packs, which we have then gone and did partnership with the retailers, like the grocery chains. In their POS deals now, you have find Aponjon gift packs, which hardly 1,200 taka, which is 800 rupees. You can pay, and the mother can be supported for, during her pregnancy and the full year of her child's age, so almost 2 years. We have gone and struck partnerships with somebody called Multimode, who distribute and make seeds for farmers. So they have a large farmers network. And thus, it is an in-kind sort of a contribution where we have said that we will use our communication channels, your BTL channels, your seed packets, the calendars that you give to your farmers. Can we put the Apanjan shortcode there? We have gone and talked to social marketing company, SMC, and said, do you want to put 5 seconds of your little bit of message at the end of our health message? Again, questions comes. What about diluting the message that we are giving? And things like that. So it is very strictly things like or saline, or I don't know, it's called electrol or in India, like related products, saline products or hygiene products that we take ad revenue from. So yes, and of course, still there's a chunk that consumers pay. Have we broken even? No, not yet. The business model says that if we can reach the 3 to 5 million people in 3 years that we have, we will. So yes. This is for you nice people to go to our website and sponsor a mother.
Great. Thank you.
Thank you.
To the expectant mother as well as the husbands. So how do you connect these two different
Right.
individuals with different numbers?
Yeah. So there's an option of either if the mother and the father have separate mobile phones, then they will get the message on their respective number, and they are connected with the relationship of that this is the primary subscriber and this is the secondary subscriber. If they have same phone that they use, then yes, unfortunately the message, 2 different messages get delivered on the same phone because they use the same handset.
All right, thanks.
Can you talk a little bit about the experiences, the learnings between the rural and the urban market? Because you said you've done a bit of both, and there have been interesting challenges and learnings along the way. So both the urban versus rural in general, but also in terms of how you've been able to grow and scale the program in both of these different sort of geographies.
Okay. Mainly it's a rural focused program. However, we completely understand and we see that people living in suburbs, which we call suburbs in maybe in English, like small towns or on the outskirts of the city, there is a lot of ignorance, and we don't have to look too hard to find somebody, a friend's friend or a relative's relative, who, if they knew the information in time, could have saved the mother or the child. So we, from a perspective of content, as I have said, that it is, we have seen that the drama format that we designed for the rural audience did not work for the urban audience at all. We also saw that the urban mother likes mostly to register through SMS. Thus, we do not still have Bangla font available on phone. So it is like, what is it called? It's in English, the Bangla is spelled out in English. So we spent a lot of time in getting those spellings, near about accurate, because a lot of people use the same word in different spellings. Like we ourselves, when we SMS in English, we just use different spellings for the same word because our friends know how that works. So content was one bit. The other thing was pricing. We spent a lot of time thinking, should we make it premium for the urban audience? So far, no. We have technologically kept that option because it's differential charging. So tomorrow, if we want, we can charge them, say, 5 taka. But till now, the research shows not a lot of inclination of paying a lot of money. But we are now working on getting a mobile app, like Baby Center app or the baby diary that you were, my earlier presenter was talking about, so that that can be maybe a way of generating revenue. So we are working on getting a mobile app. Yes.
So with 2 takas per message, what is the inflection point for you in terms of reaching a break-even point that you were talking about?
Sorry, sir. I can't hear.
With 2 taka per message is what you're charging, right?
Yes.
So what is the inflection point for you to break even? I mean, what is the kind of number that you look at?
So today it is around 5 taka. It is costing us 5 taka per delivery. That is, I think, is a lot because the service is at its, we are learning, we are still learning. We have done it right at many cases, like getting the service model right, getting the partnerships, though it took time. We have a partnership with the Ministry of Health and Family Welfare, etc. But the thing is that we saw that when we went to scale, we had a lot of problems with keeping, I was telling you, incentivizing the health workers, or the amount of people now we have in our team to follow up the health worker or the focal point of the health worker. I'm just sharing candidly the details that actually happens. And I feel that going forward, those costs needs to come down. So things like, if it really is possible to have health workers using mobiles to collect this information, today they collect it through paper forms, then it is entered through a call center. So these overheads can be worked out. So 2 taka because it was either 0 or 1 or 2 or 5. We did extensive research on pricing, willingness to pay, and we found that 2 taka is where we sort of think, and the business model is 3 to 4 years, based on the numbers, if we can reach the numbers. Today, as I speak, it is more than 100,000. So it's, it's 7 months that we have launched national, so that's not a bad number.
Great. Thank you.
Thank you.